Okay, so the rules for hemoglobin are that hemoglobin prefers to bind CO2 and carbon monoxide first, but hemoglobin will bind any gas in excess, and pH and temperature affect hemoglobin binding to oxygen. So pH and temperature are separate. So a change in pH is going to affect how hemoglobin binds oxygen, and a temperature change can affect how hemoglobin binds oxygen as well. Okay, so at the lungs, what happens? So you have an increase in oxygen at the lungs, right? And you exhale, so you have a drop in CO2. And so if you have a drop in CO2, what happens to H plus? Does it increase or decrease if you have a decrease in CO2? Good, it's going to drop. And when H plus drops, what happens to pH? Does it become more acidic or more basic? It becomes more basic. And what is the pH? Does that mean it increases or decreases? Good, it's going to increase. Okay. And is the temperature warmer or colder than at the tissues? Okay, so you take in air from outside, so the temperature is going to be colder than at the tissues. Okay, so if I'm a red blood cell, all right, so in between here is going to be the plasma, right? So here's a red blood cell that comes from the tissues, right? It has low oxygen and high CO2. So let's look at oxygen first. Oxygen is going to go from the lungs into the red blood cell. So it's going to diffuse from the lung tissue into the red blood cell, because of diffusion, right? High oxygen at the lungs, low at the red blood cell. And CO2 is going to get kicked off. It's going to go from the red blood cell into the lungs. But the fact that we have a high pH and the fact that we have a low temperature is going to help oxygen bind. So hemoglobin likes to bind oxygen, right? So hemoglobin likes to bind oxygen when you have a high pH or a low temperature, right? Good. Then we get to the tissues. What happens at the tissues, right? So here's our red blood cell. We have a lot of oxygen because it just came from the lungs, and we have a little bit of CO2. What about the tissues? So tissues use oxygen. So oxygen is lower. They use oxygen for metabolism. They make CO2 as a byproduct of metabolism, so CO2 is high. If CO2 is high, what can we say about H plus? H plus is high, right? So there's protons. And if there's protons, what can we say about pH? Excess protons is going to acidify that tissue, and that is going to decrease pH, right? Because it's acidic. On a separate note, what happens to temperature? So we're going through metabolism, so temperature is going to increase, right? We're breaking bonds, we're contracting muscles, or the tissues are going through metabolism, and so temperature is going to be higher, right? So when the red blood cell gets to the site of the tissues, oxygen is going to diffuse off to the tissues, right? Because it's high at the red blood cell, low at the tissues. CO2 is going to jump on to the red blood cell. What helps that? A low pH and a high temperature, okay? So hemoglobin releases oxygen, right? Or doesn't like to bind oxygen, or has a lower affinity for oxygen when we have a low pH of the plasma, which is or low pH of the blood, and high temperature, right? So let's recap real quick. Hemoglobin prefers to bind CO2 and carbon monoxide over oxygen, right? But it's going to bind whatever gas in excess. You notice at the lungs, the gas in excess is oxygen, so it binds oxygen. At the tissues, the gas in excess is CO2, and so it's going to bind CO2, right? What effect does pH and temperature have on it then? So pH and temperature affect the hemoglobin binding for O2, right? So when you have a high pH or a low temperature, hemoglobin wants to hold on to oxygen. When we have a low pH or acidic environment or high temperature, hemoglobin wants to kick off oxygen. It has a really hard time binding oxygen. Now, this works great in a normal, healthy individual because at the lungs, we have this environment that causes oxygen to bind to hemoglobin. At the tissues, we have the environment that causes oxygen to get kicked off of hemoglobin, and so it delivers it to the tissues. In pathological conditions, though, where somebody has an acidic blood pH due to, let's say, metabolism, let's say they're going through diabetic ketoacidosis, so they're diabetic, and we'll talk about that later, but it acidifies the blood. And you drop the pH to around pH 7.2, what is normal blood pH again? Good, 7.35, 7.45. Do you have that memorized yet? And so you drop the pH to 7.2, and hemoglobin doesn't want to hold on to oxygen. And so now you have a problem that your oxygen saturation of your blood is decreasing, right? Or what happens when you have a fever, a high grade fever, high temperature, hemoglobin has a really hard time holding on to oxygen. And so you're going to need to ventilate more, okay? Good. Make sure you understand this for the exam. This is a really important concept. Okay, so let's check this. So, whoops, sorry. Or let's check your knowledge. Eraser. All right, so if I had red blood cells in a beaker containing a warm buffer, and I had 50% oxygen and 50% CO2, which gas would that red blood cell bind, or which gas would the red blood cells bind? Okay, so if we just had, let's say, a normal, body temperature beaker and 7.4 pH, and we had equal amounts of oxygen and CO2, the red blood cell would bind CO2, okay, because it prefers CO2. What happens when we shift the temperature to warm? Which gas does it bind? Good, it's going to bind CO2 because it prefers CO2 at a warm temperature. Okay, what if we make the buffer cold? Which gas is it going to bind? Okay, it's going to bind oxygen because when you drop the temperature, the hemoglobin changes shape and it prefers to hold on to oxygen more tightly. What about, that should be Anne, what about an acidic buffer? So when you drop the pH, right, it's going to bind CO2. What about a basic buffer? You increase the pH or you decrease H plus, right? A drop in protons increases the pH. It's going to bind oxygen. Good. Okay, let's move on. So hematopoiesis or hemopoiesis is red blood cell production. Where does it occur? It occurs in the yolk sac, liver, and spleen for fetuses, and in myeloid tissue, which is our red bone marrow in adults. It involves stem cells, hemocytoblasts, and series of steps. What regulates this? A hormone called erythropoietin, or EPO for short, right? So erythropoietin is a hormone that your kidney makes. So EPO for short. It's a hormone that your kidney makes, and it increases red blood cell production. Right, here's red bone marrow, right? And in the red bone marrow, you have these stem cells. Now, these are adult stem cells. Adult stem cells are different than embryonic stem cells. Adult stem cells are undifferentiated in the fact that they're going to differentiate and become all these different cells, but they are still differentiated somewhat, meaning that they're going to that they're not completely undifferentiated. So one is a myeloid and one is a lymphoid stem cell. You have fat stem cells that they can pull from you and use for stem cell therapy in your body. But the better stem cell option would be embryonic tissue. So, from the umbilical cord, or a undifferentiated fertilized egg. So when the sperm first fertilizes the egg, then you have one cell, and those cells can be put in any tissue and develop into any tissue. And so you can actually grow different types of tissue. So, for example, you can use scaffolding for, I think they've done an ear so far. They've done a lot of different things. But you can use scaffolding for an ear and then put stem cells on that ear scaffolding and put some ear tissue, and it'll grow. It'll regenerate the tissue for the ear. So it's really cool. Okay, so let's look at the lymphoid. So the lymphoid stem cell is going to give rise to the lymphocyte, right? Pretty straightforward. The myeloid stem cell is going to give rise to everything else. So it's going to give rise to your red blood cells, your megakaryocyte, which then breaks up into platelets or fragments into platelets. It's going to give rise to your granulocyte, which is then going to give rise to your neutrophils, eosinophils, and basophils. Also, it's going to give rise to your monocytes. These guys are your white blood cells, platelets, and red blood cells. So these stem cells give rise to all of your blood cells, or your formed elements. For red blood cells, they start as a proerythroblast, day one. You don't have to know the whole sequence, but just so you're aware of it. Erythroblast, day two, right, is a basophilic erythroblast. Then day three, it's a polychromatophilic erythroblast. Day four, it's a normoblast. And then it's a reticulocyte, right? So the nucleus gets ejected. Remember, the mature red blood cells don't have a nucleus. And so day 5 to 7, it's a reticulocyte. This is in the bone marrow. Reticulocytes you typically don't see in the plasma, right? They stay in the bone marrow. And then once they turn into a red blood cell, then they get kicked out of the bone marrow and they're a functional red blood cell. You see a lot of red blood cells if you looked at a sample of blood, and you would see very few reticulocytes. If you see a lot of reticulocytes in blood or in your plasma, that means that something's going on where these guys are getting kicked out too early, or you're making excessive amounts of these guys. Okay? So let's kind of look at a little bit of how the pathology works. What regulates red blood cell production? It's going to be a decrease in oxygen. So let me back up and say for lab 1, you guys did a chemoreceptor reflex, right? So you looked at an increase in CO2, and that's going to trigger your chemoreceptors to take a breath. So taking a breath is based off of CO2. But how do we make more red blood cells? What's the feedback loop for making more red blood cells? It's going to be a drop in oxygen. So oxygen drops in the blood. Kind of weird. Your kidneys sense it. And your kidneys are the sensor and the integrator. And this, again, is a hormone pathway. So hormone pathways aren't as straightforward as nervous system pathways. The kidney is going to release erythropoietin. Erythropoietin is going to target the red bone marrow, and the red bone marrow is going to increase red blood cell production. If you have more red blood cells, you can bind more oxygen, so oxygen goes up. When do we trigger this pathway? Let's say we go up to Big Bear or Victorville, you know, the high desert, where there's less oxygen because altitude's higher, right? The higher you go in altitude, the less oxygen there is. That's going to trigger your kidney to release erythropoietin. Let's say you're a cigarette smoker and you know that you've been 30 years of smoking cigarettes, that damages the lung lining so that you can't get as much oxygen in, and so that's going to increase erythropoietin, right? So there's several different instances of when this would happen. My cat actually had kidney failure due to old age, and when she had kidney failure, one of the things was that she became anemic because she couldn't make erythropoietin to make more red blood cells. Okay, so if oxygen levels are normal, there's no trigger, right? If oxygen levels drop at the kidney, then erythropoietin is released and we go through the whole feedback loop. What do we need to make red blood cells? We need amino acids, right? Because we need to make those globular proteins. We need iron, we need vitamins B12 and B6 and folic acid. There are different types of anemia. I don't expect you to know all the different types of specific anemias, but I want you to know generally different how anemia works. So one type of anemia is if your GI tract can't absorb vitamin B12 because your stomach doesn't make enough of this chemical called intrinsic factor. So if you're not making enough intrinsic factor, you can't pull in vitamin B12. And if you can't pull in vitamin B12, you're not going to make enough red blood cells. If you have this issue, it's called pernicious anemia. What do we do with those red blood cells? So old and damaged red blood cells end up in the liver and spleen and bone marrow, where they're engulfed by macrophages and they're recycled. So you're obviously not going to just excrete this stuff out as waste. You're going to recycle what you can and then kick out what is left over as waste. So your iron is going to go back to the red bone marrow to make more hemoglobin. Your proteins and lipids are going to go to sites of protein and lipid synthesis. So they're either going to get degraded for fuel or you're going to recycle them. Your heme groups are degraded in the liver to bilirubin, right? So I'm sure you've heard bilirubin before. Heme groups are degraded in liver to bilirubin. So what ends up happening is that heme group goes from heme, right? So we have heme. Goes and degrades into biliverdin. And what color is biliverdin, would you guess? Verdin, green, right? And then it goes into bilirubin. What color is bilirubin? Yellow, right? Bilirubin is excreted in the bile of gallbladder, and then it passes out of the body in feces. So it goes into your duodenum, right? So into your intestine, your small intestine. And as it goes through your digestive tract, it oxidizes and it ends up turning that brown color of feces or poop, right? So bilirubin is excreted in your bile. What's the purpose of bile? The purpose of bile is to emulsify fats. So really interesting. So your heme gets degraded to biliverdin and then to bilirubin. And then bilirubin gets put in bile or it gets converted to bile. It actually gets converted to bile in your liver, but then bile is stored in your gallbladder. Right? And so bile is stored in your gallbladder. It's kicked out into your small intestine when you have fats. It helps emulsify fats, so it breaks it into smaller fat droplets. And then as the bile goes through, or as the degraded heme protein goes through the intestine, it oxidizes and goes from that yellowish green color to brown. Okay. Excess bilirubin results in jaundice. Okay. And so what happens, let's talk about jaundice for a second. We'll go back to the babies, right? So let's say a baby was just born, or a fetus was just born, and so it's a newborn or a neonate. They are breaking down their gamma heme subunits, so their fetal hemoglobin, excessively and making adult hemoglobin. And so if they're excessively breaking down hemes, that's going to be an excess of biliverdin and an excess of bilirubin. And so just because you have a lot of red blood cell destruction, you get accumulation of bilirubin in the tissues. Another thing too is this happens in the liver, and there are enzymes that do these different steps. And so when you have a newborn, the liver isn't as functional as an adult liver. It doesn't have all those enzymes yet. And so you get accumulation of intermediates because you're not breaking them down completely. So you can have bilirubin, or the yellowing of the skin, right? The jaundice, the yellowing of the skin. Usually you see it in the whites of the eyes first, and then in the skin. But you can be jaundiced whether if you are breaking down excessive amounts of heme, or if you're not completely breaking down that heme to bilirubin. So I know that confuses students, but either way, you're going to have some bilirubin, and it's not all going to get kicked out. You also see jaundice or accumulation of bilirubin in the eyes when somebody has hepatitis, right? So any damage to that liver, hepatitis B damages the liver so that they can't process the heme or break it down effectively. So there are a lot of different instances. It's just people are more familiar with the newborns. How do you break down bilirubin in newborn tissue? Good, you expose them to UV light. So UV light is actually going to break down the bilirubin in the skin. Okay, so red blood cells live to about 4 months, and they're recycled at the rate of 200 billion cells per day, so you can imagine. Oh, I remembered something else. So let's talk about the newborn poop, right? So because they're doing so much red blood cell destruction, their first poop is this blackish tar color, and so it's called meconium. So the first poop that newborns have is that meconium, and it's that blackish color. And if you've had a baby, you know that they go through stages. So for a little bit, they'll have some green poop because the digestive tract is still maturing, and they're not just kicking out a bunch of heme groups, are actually degrading it a little bit to biliverdin. And so you're getting that green poop, and then you'll notice that, you know, a couple more months, it turns to this yellowish poop. And then about, I think it took my son about 7 months, 6 months or 7 months to actually have the brownish poop. Okay. And so it takes the liver time to mature and develop all those enzymes to process the heme. And it takes a small intestine time as well to develop absorption of the nutrients and slow down this whole process of kicking nutrients straight through the intestine. You know that when you feed them breast milk or formula, it goes through that intestine pretty quickly, especially when they're a newborn. And then as you start feeding them more solids, it takes a little bit more time. And as that intestine gets coordinated with contraction and digestion, it gets more efficient at absorbing nutrients. So it's really kind of slows stuff down a little bit. So it's really interesting. Okay. Here's erythrocyte life cycle, excuse me. So let's start at the bone marrow. Here's erythropoiesis. You're going to make erythrocytes. They're going to get dumped into the blood. They're going to get pulled into the spleen after 4 months, degraded into heme and globulin proteins. The globulins are amino acids. They're going to get used by the body. The heme is going to get broken down to iron and bilirubin. The iron is going to go back into the bone marrow to make more red blood cells. The bilirubin gets converted to bile in a series of enzymatic steps, right? There's intermediates and enzymes here. that bile is going to get kicked out in the gallbladder, or excuse me, it's going to get stored in the gallbladder and kicked out into the intestine to emulsify fats, right? Some of it, though, however, actually goes into the kidney. So some of it is going to get filtered out of the kidney and excreted in the urine. And so that's going to give the urine that yellowish color. When oxygen levels are low, erythropoietin is going to increase red blood cell production. Okay, so here's your little erythrocyte life cycle. I put this picture in too because I really like the color coding. It makes more sense to me, but it tells you the same thing. So your macrophage is going to degrade, your macrophage in the spleen and liver and bone marrow are going to degrade the heme into biliverdin and bilirubin. The liver is going to put the bilirubin as bile in the gallbladder, right? And then I like how it kind of goes through the whole process. It's a little bit more detail. It gets kicked out in the urine. Hemoglobin can get kicked out in the urine. It's not common. And then you start the whole process over again. Okay, red blood cell measurement. So this is what we're going to be doing for lab. So a CBC, or complete blood count, is going to give you the number of red blood cells, the hemoglobin concentration, the hematocrit, so the packed red blood cells, the number of white blood cells, the differential white blood cell count, so how many of each type of white blood cell you have, like how many neutrophils, basophils, eosinophils, monocytes, and lymphocytes you have, plus the different types of nutrients. So what's glucose level, what are your ions, et cetera, et cetera. And so it's going to tell you everything. It's going to tell you if there's something going on. Okay, so let's look at the normal ranges for red blood cells. Males are 4.6 to 6.3 million per cubic millimeter. Females a little bit lower, 4.2 to 5.5 million per cubic millimeter. I would like you to memorize all these numbers. Just pick a number that makes sense to you. So you can either memorize a low range or pick a number in between that. Like typically when I talk about red blood cell count, I talk about, 5 million per cubic millimeter. Why are males higher than females? So why is that number higher? It's higher because males have what hormone? Good, testosterone. So males have testosterone, increases metabolism. That's going to increase the demand for oxygen, and so they're going to have more red blood cells. Number of white blood cells. Notice, generally speaking, it's not differential, right? So how many white blood cells should somebody have? About 10,000 white blood cells per cubic millimeter. And then the differential will tell you how much of each type of white blood cell you have. And that's going to tell you what type of an infection you most likely have. Hemoglobin concentration of blood, right? So hemoglobin concentration of blood, males 14 to 18 grams per deciliter. So grams per deciliter, grams per 100 mils. Females 12 to 16 grams per deciliter. So think about that. If you had 100 mils of blood, you would have about 15 grams of hemoglobin. That's just crazy, right? That's a lot of hemoglobin. There was something I was gonna say. Oh, I remember. For lab, so for the blood lab, you're gonna measure these. So you're gonna measure hemoglobin concentration of blood. You're gonna measure hematocrit and red blood cell count, and then you're gonna do blood typing virtually, right? So hemoglobin concentration, how do we measure hemoglobin? There are many ways, but the one way that we're going to do that is with the Telquist scale. So the Telquist scale is a color scale, and we'll talk about it once we get to lab. The Telquist scale, basically, it's a piece of paper. You drop a drop of blood onto it, and then you match it up with the color scale, and it tells you how much hemoglobin you have in your sample. All right, hematocrit, or HCT, is a fraction of blood that is composed of red blood cells. So hematocrit is read using you're going to use a capillary tube, suck up the blood, spin it down, and then read how much of the blood is packed red blood cells. Females hematocrit, about 36 to 48%, males 45 to 53%. Newborns have more red blood cells, so they're going to have more hematocrit. Again, red blood cell production, remember, will increase or decrease with oxygen or blood loss due to erythropoietin. Here's an example of hematocrit, right? So if we could do this in lab, you would suck up blood into a capillary tube. This is a capillary tube. And you'll actually see mine for lab. So you're going to suck up blood, and then you're going to put it in a centrifuge with the clay side out, right? And then the centrifuge is going to spin around super fast. And if you didn't have the clay there, you would actually lose your sample. The blood would go all over the walls of the centrifuge. Not very fun. But you spin it around really fast, and what ends up happening is all the red blood cells collect in this region, right? And the plasma is right here. So this is what we're looking at. So here are the packed red blood cells, and here's a plasma. Okay, so this is a capillary tube, right? How do we read hematocrit? So we line up the packed red blood cells with the 0 mark. Okay, it's hard to draw. And then we line the top of the plasma with the 100 mark. And you'll see in lab that this is it's a scale, if you will. And then you read the interface. So for sample A, what do you think the value is? What's the hematocrit? Yeah, it looks like it's about 48% probably. So hematocrit for A would be 48%. Actually, that's right here. Sample A is 48%. What about sample B? Sample B looks like it's about 45%, right? Okay, so let me ask you a couple of questions. Which one is male? A or B? Good, A. Why would you say that? Higher hematocrit. Which one is female? B. Why do you say that? Good, lower hematocrit. Which one is someone, let's see, at sea level? B, right, lower. Which one is someone at a higher elevation? Like, I don't know, 8,000 feet above sea level, or let's say Mount Baldy or Big Bear. Good, letter A. Why? Less oxygen, more erythropoietin, more hemoglobin, or more red blood cells. Good. Here's a tricky one. Which person is dehydrated, severely dehydrated? And so when you're severely dehydrated, you've lost plasma volume, but you haven't lost packed red blood cells. So you've lost plasma, so plasma's less, so that artificially raises the amount of red blood cells. Good. So letter A would be the one who's dehydrated, right? When you lose plasma volume, right? When you lose plasma volume, oops, sorry. Let's say we've lost plasma volume. So let's say we've lost this to dehydration. So on the scale, you line up the top of the plasma with the 100 mark. So this is now the 100 mark, and this is artificially higher, right? This would be at the 60 mark. And so somebody who's dehydrated because they've lost plasma volume, their red blood cell, packed red blood cell amount looks higher, or it's artificially higher. Good. Okay, what do we use these for? So aside from these 3 indices, red blood cell count, hemoglobin concentration, and hematocrit, we can use them to figure out the average size and average concentration of hemoglobin for red blood cells in circulation. So we can figure out the mean corpuscular volume, the mean corpuscular hemoglobin, and the mean corpuscular hemoglobin concentration. These 3 means give us they're used to diagnose different types of anemia. What is anemia? The definition of anemia is a decrease in oxygen carrying capacity of the blood, right? So this could be you don't have enough red blood cells. This could be you don't have enough hemoglobin in those red blood cells. It could be both. It could be that you have a slow leak somewhere and you're losing red blood cells, right? It could be that you're dehydrated. It could be that there are multitudes of anemia, okay? But generally, anemia is a decrease in oxygen carrying capacity. There was something I was gonna say. Oh, yeah, let me say a couple of things here. So for the red blood cell stuff, when you talk about the red blood cell lab, there's actually a virtual website, and I'll put it on our lab handout, but I want you to be aware of it at McGill University. It's in Canada. You can go to Google and type McGill University Virtual Physiology Lab. Okay, and they have a bunch of different physiology labs. The one that you can look at is the red blood cell lab or the red blood cell indices. Okay, they have other ones too. I think I have you guys read it for spirometry. I'm going to have you look at it for blood. Okay, because it goes through a lot of stuff that we're going to do in lab. Also, for the hemoglobin stuff, for the pH and whatnot, you can look at Khan Academy. Look at, I don't know if it's blood or if it's hematology, but look at search MCAT, whoops, sorry, MCAT review. Okay, good. All right. And so then I go over the calculations, and you're going to need these for lab. So mean corpuscular volume is the average volume of a red blood cell. How do we calculate it? It's hematocrit in percent times 10 divided by your red blood cell count. Normal range is 80 to 95 femtoliters. I will give you the equation on the lab exam, but I want you to know normal ranges. Okay, so I'll give you numbers in the equation. You just have to calculate it and plug and chug and figure out the normal range. So don't forget your calculator when you're taking your lab exam. Mean corpuscular hemoglobin, average amount of hemoglobin in an average red blood cell. How do we calculate? Hemoglobin times 10 divided by red blood cell count. Is that okay? Normal range, about 30 picograms per cell. Mean corpuscular hemoglobin concentration, average concentration of hemoglobin in a given volume of packed red blood cells. Here's how we calculate it. Normal range, about 30 grams per deciliter. Okay, here's a chart. So here's your test, right? This is what it determines, and it gives you the normal range. If they're elevated, so if you have a high hematocrit, that means you have polycythemia, which is excess red blood cells. Notice that it could be excess red blood cells or excess white blood cells. Usually it's excess red blood cells. Polycythemia, so if you have a high red blood cell count, you have too many red blood cells. It could be because you're not getting enough oxygen in, whether you're up at Big Bear or you're a chronic cigarette smoker. If the volume is big, that is a macrocyte. That means your red blood cells are larger than normal. If your hemoglobin concentration is higher than normal, your red blood cell is going to be hyperchromic. Hyper means more, chromic means color. Depressed values, all of those are considered anemia, but take a look. If mean corpuscular volume is low, that would be microcytic anemia, meaning your red blood cells are small, and they're small, and that's a type of anemia, so microcytic anemia. If you don't have enough hemoglobin, then your red blood cells are going to be lighter colored, so they're going to be hypochromic, less color. Elevated red blood cells can be due to dehydration, kidney disease, low blood O2, polycythemia, and smoking. It could be blood loss, malnutrition, destruction of red blood cells, or not producing enough erythropoietin. you don't have to know all of these. I just generally want you to know anemias and how to think through some of this stuff, right? So hemorrhagic anemia example would be caused by blood loss, right? Hemolytic anemia, excessive red blood cell production. Aplastic anemia, you can't make enough red blood cells because your bone marrow has been damaged. Let's say you're going through chemotherapy or chemotherapy treatment, it's going to destroy those cells. Sickle cell anemia, it's an inherited hemoglobin mutation. We talked about this earlier. That's a form of anemia. Polycythemia, excessive red blood cells. You may think that's a good thing. It is to a certain extent, right? But then if you have too many red blood cells, your blood becomes really viscous and you can't get enough oxygen loaded onto them. That causes cyanosis, which is bluish skin, right? Because you're not getting enough oxygen to the tissues, and blood clots. Think about how these would affect your typical blood planner. You can skip this, I don't ask this, but hemoglobinuria, symptoms of hemolytic anemia. So if your red blood cells are getting destroyed excessively at the liver, you're gonna kick out hemoglobin in the bloodstream. Hematuria can be a symptoms of UTI, bacterial infection. This would be whole red blood cells in the urine. Okay, let's talk about white blood cells. White blood cells, they're about the same size. They're larger than red blood cells. Some of them are really big. Okay, they have a full range of organelles. There's about 10,000 white blood cells per cubic millimeter. What's the purpose of them? They're attacking invading organisms, removing toxins, waste, and damaged cells throughout your body. They actually use the bloodstream. People think that they live in the bloodstream. They don't. They're not that's not their home. They use a bloodstream to travel, and then they migrate in and out of the bloodstream and go into tissues and clean up the bacteria, the viruses, the damaged cells, what have you. Okay. These guys are really interesting. So they use different types of ways of getting around in the tissue. So they use diapedesis to squeeze through capillary walls. They use amoeboid movement once they're outside the bloodstream. So amoebas are single-celled organisms. They move around like them. They use chemotaxis, so chemicals released from damaged site or inflamed site to attract the white blood cells. They're going to use that chemical trail. And they go through phagocytosis, or they're phagocytes. So some of them will actually ingest bacteria and debris, like neutrophils. Neutrophils are predatory. They'll go and search out bacteria and eat them. Eosinophils will go and search out parasites and eat them. Okay, so here are your white blood cells. I want you to know, for lab, I want you to be able to identify each one of these, right? And I want you to be able to tell me normal range. And if they're elevated, what is a reason why, or what disease state would that be? For lecture, I want you to be able to give me a description of these, right? Because lecture will be multiple choice, and then give me normal ranges and give me a reason why they would be elevated as well. Okay, so the first one, obviously it's labeled, right? So the first one is a lymphocyte, second one is a basophil, third one is a monocyte, fourth one is a neutrophil, and fifth one is an eosinophil. Which one is the most abundant? It's going to be neutrophils, right? So how do we remember that again? I think I told you. Oh, it was in lab. So let's go through that. So if we're talking about frequency, so the most abundant would be neutrophils, right? Then what's next? Monocytes. Then, whoops, sorry guys, I did it wrong. Eraser. So how do we remember the order? Never let monkeys eat bananas. So what comes next? Never let, L would be lymphocytes, right? Okay, never let monkeys for monocyte eat eosinophil. Oops. And then B for basophil. Okay, so this is the most abundant neutrophils And the least abundant would be basophils. So never let monkeys eat bananas. Okay, so let's look at the description of these guys. So neutrophils, they're either going to have a banded nucleus if they're immature, or a segmented nucleus like you see here if they're mature. They're going to be a little bit larger than the red blood cells. Typically, the nucleus is like a purplish color, and the cytoplasm is going to be a pinkish red. Usually I don't condone memorizing colors, but with these guys, it's always going to be those colors because they go through a red stain and then a blue stain. And so each white blood cell picks up a different amount of stain. Okay, so this is called a granulocyte because there are granules in the cytoplasm. It is also called a polymorphonuclear leukocyte because it has many lobes to the nucleus. Okay. Let's look at the other granulocytes. So the eosinophil is the other granulocyte, and they're rare. These guys pick up the eosin stain, so they're called eosinophils because they love that eosin acidic stain. These guys kind of look like aliens. So if you see them in lab under the microscope, you'll see a dark purple nucleus. It's like a bilobe nucleus. And then the cytoplasm is red. Okay. I don't think this picture does it justice, but they really look like an alien face, and they're really big. Basophils are another type of granulocyte. These guys are blue, and so they have a lot of granules in their cytoplasm, so much so that you can't even see the nucleus. And they pick up that basic stain, that basic blue stain. Those are the granulocytes. The agranulocytes, or the ones that don't have granules in the cytoplasm, would be your monocyte and your lymphocyte. Monocyte, notice that the cytoplasm is clear. I know it doesn't look that clear to you guys, but it's clear. There's no granules. And the nucleus is kidney bean shaped, right? Lymphocytes, again, clear cytoplasm, but it's just a sliver of cytoplasm. It's not a lot. The nucleus takes up a lot of the cell. And lymphocytes are about the same size as red blood cells. As the lymphocytes and the monocytes mature, they add more cytoplasm. As the neutrophils mature, they add more segments to their nucleus. All right, let's look at when they're elevated. So neutrophils, 50 to 70% of circulating white blood cells, they have granules that are lysosomal enzymes and bactericides. So bactericides would include hydrogen peroxide and superoxide, and so they're going to kill bacteria. What do these guys do? They will actively search for bacteria and kill them. So if you have a bacterial infection, this is when they're going to be elevated, right? So they're going to attack bacteria. I want to show you a video. Let's see. Do you share desktop? Let's see if this kicks me out. Hopefully not. Okay, so let's go to Chrome. Actually, I want to do Safari. It'll probably pull up in Safari. Let's see. Neutrophils. Oops, good thing I can spell. Neutrophils attacking bacteria. Okay, so let's find a video of this. Here, so let's watch this video. So here is a white blood cell. Here's your neutrophil, and it is attacking bacteria. So let's take a look at this. Okay, can you see that? All right, let's watch it. So here is the white blood cell, and here are some red blood cells, and then this is a bacteria. And so do you see the neutrophil chasing the bacteria. And then look at what happens when it grabs it. Right? It's predatory. So it's just going to go after that bacteria and then it's going to engulf it. So it's going to phagocytize it. And then it goes on to the next one. That's kind of a bad video. Sorry, you guys. You can look it up. There's a bunch of different ones. Okay. The next one that I want to show you is the eosinophil. So we'll talk about the eosinophil. The longer one is probably the better picture. Eosinophils attack parasites. Okay. And so here is a video of eosinophils attacking. It's actually C. elegans, but it's the same type of idea. It's a research worm. Okay, so let's take a look. So here are all of the eosinophils, and bam, they're going after that worm. All right, so that's what they do to parasites. Okay, pretty cool. Okay. All right, so neutrophils, they're first to attack bacteria. They're gonna form pus when wounds are healing. Oops. They're going to release prostaglandins and leukotrienes, so those are locally acting hormones, to send more white blood cells to the area. Here's a neutrophil. This is a better picture of a neutrophil. So grainy cytoplasm, dark purple nucleus. Is this mature, immature? It has segments, so it's mature. Okay, let's talk about the eosinophil and the basophil next. So eosinophils are also called acidophils. The eosin stain is an acid. There's the range. They're going to attack large parasites. They excrete toxic compounds. They're sensitive to allergens, and they're going to control inflammation with enzymes. Okay. There's your eosinophil. Basophils release histamine and heparin. Okay. So they're going to accumulate in damaged and inflamed tissue. They're going to release histamine, which is going to dilate blood vessels, and they're going to release heparin, which prevents blood clotting. And so when you have an infection or when you have inflammation, basophils and mast cells are going to come to that area, and the basophils are going to release these, and that's going to cause the redness, the swelling, and the heat that you feel with inflammation. And that's why you can't see the nucleus, because they also have serotonin, which kind of calms things down. And here's your basophil. And you can't see the nucleus because they have so many grains. They have histamine, heparin, serotonin. Monocytes, they enter peripheral tissues and become macrophages. They engulf large particles and pathogens. They secrete substances that attract the immune system and fibrocytes to that damaged area. Okay. Whoops, how do I get to the next slide? Here's a monocyte, right? So kidney bean shaped nucleus. And then let's talk about the lymphocytes. Lymphocytes, 20 to 30 of white blood cells, larger than red blood cells. They migrate in and out of blood. They're mostly in connective tissue and lymphoid organs. So they actually are called lymphocytes because they mature in your lymph nodes. And so when the lymph tissue comes from the capillaries and your extremities into the lymphatic lymph nodes, your lymphocytes are going to attack the bacteria and viruses. And so they're part of the body's specific defense system. There's your lymphocyte. You don't have to memorize the 3 classes of lymphocytes. You're going to cover this in micro and immunity. So, but the 3 classes of lymphocytes, there's B cells, mature in bone marrow, T cells, mature in thymus, and natural killer cells. So there's 3 different types, and they have 3 different functions. All blood cells originate from hemocytoblasts, right? Myeloid stem cells differentiate into progenitor cells, which produce all of your white blood cells except your lymphocytes. Your lymphoid stem cells go through lymphopoiesis and produce lymphocytes. Here's a picture. Myeloid stem cells give rise to these guys. Lymphoid stem cell give rise to lymphocytes. Okay. White blood cells develop fully in the bone marrow except for monocytes. Monocytes are going to mature into macrophages in peripheral tissue. Differential white blood cell count is going to tell you what type of infections going on or inflammation or allergic reactions going on. And so we talked about if neutrophils are elevated, that's an acute bacterial infection. If eosinophils are elevated, that's a parasitic infection, or allergies like hay fever, what have you, asthma. If basophils are elevated, it is due to an acute allergic reaction. Let's say shellfish, you're allergic to peanuts, or you have some type of inflammatory response going on in the body. Lymphocytes would be viral infections, and then monocytes would be long-term infections. And of course, there are a lot of infections that fit under these rules. I don't want you to know everything, but I just want you to have a working knowledge of this when you get into your professional programs. So disorders, leukopenia is abnormally low white blood cell count. Leukocytosis is abnormally high white blood cell count. So let's say you have an infection. You would probably have leukocytosis or abnormally high white blood cell count because you're fighting off that infection. If you're going through chemotherapy or cancer treatment, you would probably have leukopenia because the chemotherapy drug is going to target rapidly dividing cells, and that would be the cells in your bone marrow. Leukemia is extremely high white blood cell count. So leukemia is cancer of the bone marrow. It's because those precursor cells are turned on and they're rapidly dividing and they're not stopping. So it's considered to be cancer. And so any cancer of the bone marrow is called leukemia. Over. Oops, okay. All right, so leukemia is uncontrolled white blood cell production. How do we know it's leukemia? Because the immature white blood cells that should stay in the bone marrow get kicked out into circulation, and so you actually see them in circulation. Myeloid leukemia is excessive myeloid stem cell production, so you see a bunch of granulocytes kicked out, like the neutrophils, eosinophils, and basophils, kicked out before they're mature. Lymphoid leukemia would be excessive lymphocytes from lymphoid stem cells, and these don't look normal. So when we do a differential white blood cell count, we look at normal cells first, right, to figure out what those normal cells look like, and then we would look at the abnormal ones or the cancer slides because they look so different from normal white blood cells. Okay, let's talk about platelets. So platelets are thrombocytes. They come from megakaryocytes in the bone marrow. There's 200 billion produced daily. They live 3 to 5 days. Here's normal range, so about 300,000 per cubic millimeter. What are the functions of platelets? They release important clotting chemicals. They temporarily patch damaged vessel walls and actively contract tissue after clot formation. So platelets are responsible for stoppage of bleeding, okay? So let's talk about hemostasis. What is hemostasis? Hemostasis means stoppage of bleeding. What do we need? We definitely need vitamin K, which is absorbed from the gut to the liver to make your clotting factors. We need calcium, all right? There are 3 phases, general phases: vascular spasm, platelet plug, and coagulation. Coagulation is clotting, okay? Agglutination is an antibody binding to an antigen. So make sure you write that down. Coagulation is blood clotting, requires a series of steps. It's a cascade mechanism. Agglutination is completely different. Agglutination is what an antibody does to an antigen. So an antibody is going to bind to that specific antigen, right? People get it mixed up because we talk about agglutination in the red blood cell lab when we're talking about blood types. Okay, so let's talk about the different steps. So vascular spasm is when you injure a blood vessel, that blood vessel starts spasming. Neurotransmitters are going to be released from platelets that's going to cause spasming. And this happens in small blood vessels, right? So those small blood vessels start spasming and closing shut, and then they're going to stop bleeding. So let me back up. So when that vascular spasm occurs due to injury of that blood vessel, it's going to stop bleeding. And so when you're looking at someone's bleeding time versus clotting time, or bleeding time versus coagulation time, bleeding time is a time it takes for that blood vessel to spasm or close shut. And so that's about 2 minutes, whereas coagulation time takes way longer, because coagulation time is a bunch of clotting factors, and you have to activate those clotting factors. So it takes a while. And between that is your platelet plug. So your platelet plug, it forms, the platelets become sticky, they stick to each other, they stick to endothelial lining and collagen and one another. And these are in the larger vessels. It's believed that the COVID virus actually affects blood clotting and affects the platelets, so that you form more clots in the lungs and in the tissue, in excessive clot formation. So they're still studying COVID-19. This is summer of 2020. So there's still a lot of information that they don't know, but it's a really interesting virus from a physiological standpoint. Coagulation is blood clotting. So this is the most effective for stoppage of bleeding, but it involves a series of steps. So let's look at blood clotting or coagulation. So here's damage to that endothelial lining. The platelets stick to it, right? So the platelets stick to it because of chemicals released by this damaged environment. And this damaged environment will start spasming so that you're not losing blood, right? Then the platelets release thromboxane and ATP and more chemicals that attract more platelets. Notice that the platelets stick to each other, they become sticky. They have fibrinogen attaching one platelet to another, okay? Fibrinogen is soluble in water. Once we go through, and listen to me carefully, once we go through the clotting mechanism, fibrinogen becomes insoluble fibrin. So fibrinogen is soluble in water, right? Once we make all the clotting factors, this is going to turn fibrinogen into fibrin. So that's the last step. Once we make fibrin, these platelets are stuck together and it's insoluble in water and they're not going to move. Okay, so the goal of the blood clot is to cover the damaged area so that the damaged area heals, and it's going to heal from down here inward, or up towards the surface. If you think of a wound that you have on your skin, you know the healing process. So it's cut, it bleeds, it finally stops bleeding. But if you whack it again, it's going to start bleeding, right? If you get a paper cut, because you haven't formed a blood clot, you just had a vasospasm. And then once a blood clot forms, eventually it's going to form a scab, and then that scab is going to get reabsorbed. And so it's the same thing in the body, right? My father had a pulmonary embolism once, and this was before he was on anticoagulants, and it was a big pulmonary embolism, but they decided that they weren't going to do surgery, that they were going to wait and just let the body reabsorb it. And so what ends up happening is they gave him anticoagulants so that he wouldn't form any more clots. And then they let the body break down and reabsorb that blood clot. And so within a couple of months, that pulmonary embolism was gone. It's really interesting. Okay, so let's look at coagulation. It's a complex multi-substance, multi-step process. It involves prothrombin activator, PA, or thromboplastin, which is released by damaged tissue. These are also called different factors. So when you look coagulation up, you'll see an intrinsic pathway, an extrinsic pathway, and then the common pathway. This is the common pathway. I didn't have you memorize all the Roman numerals or what have you. I just give you these names because this makes more sense to me. And so now you have to learn it that way. But just know that we're talking about the same thing if you've had this before. in some way, shape, or form. Okay, so prothrombin activator with calcium and other factors is going to convert prothrombin to thrombin. Once thrombin is formed, it's going to convert fibrinogen, right, into fibrin, and fibrin is insoluble, and so that's going to make the mesh net that's going to trap the platelets and the red blood cells forming the clot. You can read that. Here's the picture. I like the flow chart better. So here's a damaged blood vessel. The connective tissue is going to be exposed, so you release chemicals. That's going to take inactive clotting factors floating around in the plasma that are made by the liver and convert them to active clotting factors. Active clotting factors are going to get converted to prothrombinase, which is an enzyme. ASE means it's an enzyme. You need calcium and platelet chemicals to do this, so calcium is important as well. Where does the vitamin K come in? Vitamin K actually makes these different types of clotting factors in the liver, and so all these guys are made in the liver. Once we have prothrombinase, that is going to convert prothrombin into thrombin. And once we have thrombin formed, it's going to convert fibrinogen into fibrin. And so that's what ultimately makes a clot. Notice how it's a multi-step process, so this takes time. So blood clotting, if you look at the fake data for the blood lab, you'll notice that blood clotting takes about 6 minutes. So stoppage of bleeding occurs up here. That's about 2 minutes. And blood clotting is a positive feedback mechanism that ends up with a clot, and that takes some time. What happens if you can't make one of these clotting factors? So let's say, excuse me, you don't make enough of a clotting factor, you're going to have an issue with making a blood clot. And so hemophilia is a bleeding disorder. It can be due to less production of a clotting factor or no production of a clotting factor. And so it's like a sliding scale of how serious it is. But hemophilia is inherited, a genetic mutation where your liver can't make some of those clotting factors. Okay. Thrombocytopenia is platelet deficiency, right? If you don't have enough platelets, you obviously can't form a blood clot, and so that can lead to hemorrhage, right? Hemophilia, which we just talked about, is a genetic disease that affects clotting factor genes. People who have hemophilia have various degrees of bleeding, right? But the more severe cases of hemophilia, if somebody gets a cut, they have to go to the hospital and get coagulants, okay? My father, I keep using my father because he has a lot of good examples, but my father, because of pulmonary embolism, was on an anticoagulant. He was on warfarin, and he had a procedure done with his prostate, and he bled excessively, and they took him to the ER, and in the hospital, they gave him vitamin K and platelets, and they gave him vitamin K and platelets to help with the clotting. And so you will see all these different treatments that they use for clotting and to stop clotting in the body. Abnormal clot formation. A thrombus is a clot that's formed in an uninjured vessel. An embolus is a thrombus that's broken off and lodged somewhere else. So pulmonary embolism is a lung clot. A thrombus usually forms in the lower legs. So from lying around or not being active, and then it lodges somewhere else. So pulmonary embolism is a lung clot. Coronary embolism is a clot in one of your coronary vessels. Stroke would be a clot lodged in one of the brain arteries. Here's what a thrombus looks like. The last thing is your human blood types, okay? And so we covered this in lab. Sorry, we covered this in lab, and so I want you to look at lab for this for more detail, but I want you to be able to draw out your pictures and your blood typing chart, okay? So ABO blood groups is an example of codominance. So why is it codominance? Because A and B are dominant over O, right? And so O is recessive, A and B are dominant. Rh factor plays by normal inheritance. So if you have the Rh factor, that's dominant. If you don't have the Rh factor, it's recessive. Okay. How does this work? You inherit one allele for blood type from mom and one allele of blood type from dad, right? So let's draw your picture, right? So here's, I forget, I think it's chromosome 12 that codes for blood type. So let's say this is chromosome 12. Okay, here's one chromatid from mom, and then this is a chromatid from dad, right? Here's your code for your blood type, and then here's your code for your Rh factor. Okay, so if I have A here, and if I have B here, what two codes or what two alleles do I have? I have A and B, so I'm going to display both A and B antigens on the surface of my red blood cells. Okay, what if I have, for example, let's do the eraser. What if I have A and O? What is that? What blood type does that give me? Let's draw the O here, right? So if I oh, that was effective. Oh. I know, right? It just screwed up my whole slide. I'm having technical difficulties, you guys. Let's see. Okay, let's try this again. All right, so if I have O here, O is recessive, A is dominant, and so I'm going to display blood type A, okay? And then this would be having the Rh factor, and negative would be not having the Rh factor. So I would have the Rh factor because Rh factor is dominant, negative is recessive, okay? Why do we care so much about ABO and RH? Because when you donate blood or when you are giving blood or receiving blood, you have to worry about the antibodies in someone's plasma attacking the antigens on the surface of the red blood cells. So right there. Okay, you can read these, on your own. And I want you to look over or listen to the red blood cell lab because we're going to cover those in more depth. But take a look at the red blood cells. So if I have type A blood, it's called type A blood because I have A antigens on the surface of my red blood cells. I have B antibodies in the plasma. So whatever you have on the red blood cell, you're going to make the opposite antibody in the plasma, right? So blood type B, I have B antigens on the surface. So I have A antibodies in the plasma. Blood type AB, I display both A and B. And if I display both A and B, I don't have any antibodies in the plasma. If I have blood type O, O codes for nothing. So that means I don't have A antigens or B antigens. And therefore I have both of those antibodies in the plasma. Who can donate to whom? You want to usually, if you have blood type A, you want to donate A. This is what the antibody looks like. So when I talk about antibodies coming in contact with antigens, here's your antibody. It's sort of this Y shape, and it has one arm that's going to bind to one red blood cell and another arm that's going to bind to another red blood cell. And so this causes agglutination. Here's agglutination actually in blood cells. And then there's your little white blood cell. You should be able to tell what this is. Hint, it's a neutrophil. Okay, so Rh positive or Rh negative. Rh typing is based on if the Rh factor is present on the red blood cell or not. If Rh factor is present, we say that person is Rh positive, or we just say positive. They can have a positive from mom and a positive from dad, or a positive from mom and a negative from dad, or a negative from mom and a positive from dad. It doesn't matter. As long as you have one positive, they're going to display the Rh factor because the Rh factor is dominant. If they don't have the Rh factor, the two allele combination they have to have is a negative negative. One negative from mom, one negative from dad, because negative is recessive. The trick with that is if the person is Rh negative, they have Rh antibodies, but they're not going to make those Rh antibodies until they are exposed to a positive blood type. So it's a lot like when somebody has, let's say somebody catches bacterial pneumonia, They don't have antibodies against that specific bacterial pneumonia until they come in contact with it, and then they have those antibodies. So the Rh factor sort of plays by the same rules. Erythroblastosis is a condition where mom is negative, Rh negative, and she is pregnant with an Rh positive fetus, right? At birth, that Rh positive blood, the red blood cells, come in contact with mom, and mom is Rh negative. So mom is going to make antibodies to attack the Rh positive red blood cells. Now, it doesn't really matter because mom gave birth, the baby's gone. But what happens if she gets pregnant again and that baby is Rh positive, right? Those Rh positive antibodies from mom are going to actually go through the placenta and attack the fetus or agglutinate the fetus's red blood cells. And that's going to agglutinate and destroy the baby's red blood cells so that baby would die. RhoGAM is a shot that's going to prevent mom from making those Rh antibodies. So if they think that mom is Rh negative, they're going to do a blood test. They're going to measure her Rh gamma globulins and see how many antibodies she has or what the level is, and then give her the RhoGAM shot to decrease antibody production for Rh. Here's a picture to explain it better. So here's the fetus with the Rh positive red blood cells. Let's say the placenta tears or the baby is born. The red blood cells come in contact with mom's blood. So the Rh positive red blood cells come in contact with mom's body. Mom then responds by making Rh antibodies to attack the Rh antigens. And then those Rh antibodies are going to cross the placenta and agglutinate the baby's blood. Typically, the baby's already born, so it doesn't matter at that point. But if she has a second pregnancy, then the antibodies will attack that baby. Blood typing. How the heck does blood typing work? So how do we determine an individual's blood type? We're going to order antibody serum online from like Carolina or Sigma, right? And then we're going to take, let me draw you a picture quickly. We're going to have 3 wells, right? We're going to put blood in those 3 wells, the unknown blood sample. And then we're going to add anti-A. So antibody A to one, antibody B to another, and antibody Rh to another. And we're going to look for agglutination, right? So if we get agglutination in this well, it's because the antibody A reacted with the antigen A in the red blood cell. And so we say that they have blood type A. Okay, same thing with B and same thing with Rh. Whichever well agglutinates, antigens are reacting with the antibodies that are present, so we say it's positive for that blood type. Here's a picture. So here is type A blood. Type A blood is going to agglutinate when we add A antibody to it, right? Notice B antibodies don't cause any agglutination. Type B blood is going to agglutinate when you add B antibodies. And so here's agglutination for B antibodies, no agglutination for A antibodies. Type A and B, type AB blood is going to agglutinate when you have both antibody serums, okay? So when you add B and A. If we had Rh, you would see if it's Rh positive, we would get agglutination. Rh negative, we wouldn't get agglutination. Okay, so now that we finished lecture, go and talk, or go, sorry. Now that we finished lecture, go ahead and review your lab notes and listen to my lab lecture.